Great. Good evening, everybody. Thank you so very, very much for joining us. Welcome to our Building Community Power Southern Voices COVID Community Healthcare and Systemic Racism. I'm Andrea Miller. I am the founding board member for Center for Common Ground, and I am thrilled, absolutely thrilled that you were able to join us tonight. Our topic tonight is about something that it almost doesn't matter how deep a hole you've tried to dig for yourself. You have heard about COVID. For me here in Virginia, we really started hearing about COVID at the beginning of February. And in mid February, I was in New Orleans. When I came back at the end of February, I attended my last in public event with the governor's wife and a number of others as they led a march in Richmond, Virginia, to our state capitol to talk about the Equal Rights Amendment. Literally 10 days later, the state of Virginia was closed. I know there were many other states farther to the south that we were watching, and it took some states literally until the end of May to really begin to start taking COVID seriously. And I can remember when we were phone banking into Georgia for the runoffs, which had been postponed from March all the way back to June because of COVID, and people being very, very concerned. What would some of our rural voters in places like Randolph County that had really been devastated by COVID, should we still reach out to them, telling them about the opportunity to vote? And because people now had vote by mail ballots, which that may be the last time that happens automatically for a while, many, many people were able to vote safely. So, anyway, as I was saying, the pandemic totally has been in our focus and our spotlight for basically an entire year. And it has shown beyond a shadow of a doubt, exposed all of our structural problems, the structural racism that is inherent in our healthcare system, in our education system, in everything that we have considered a system. COVID has exposed this is not fair. So tonight we have two speakers. We have Professor Mark J. DeHaven from UNC at Charlotte. So we have a person working in the healthcare field, and he specifically works in community health. And we have Mr. Tony Brown, who is a community voice from Louisiana, to talk to us about COVID, community healthcare, and systemic racism. Our first speaker will be Dr. Mark J. DeHaven, a professor of public health sciences at UNC Charlotte. Dr. DeHaven is a community medicine practitioner and researcher. He's developed three different medical school divisions dedicated to community medicine and community health science research. We're an organization who has a tremendous respect for numbers. His research program has received continuous federal funding from NIH Centers for Disease Control and Prevention and various foundations for improving the health of vulnerable residents in low resource environments. Prior to his present position as director, Academy for Research on Community Health Engagement and Services, Arches. He was professor and chief division of community health sciences and vice chair and chief division of community medicine at the University of Texas Southwestern Medical Center in Dallas. So, Professor DeHaven, thank you so very much for joining us this evening. Welcome.
Thank you, Andrea. I'm very happy to be here today, and thank you so much for inviting me and allowing me to join this occasion. And I'm really pleased to be able to share a little bit now that our numbers are much clearer in terms of what we've just experienced during the last 12 months. I thought I would put on my professor hat for a little bit and walk through a few slides to kind of show where we are. Let me see if I can call these up real quick. Can you see that okay, Andrea?
Not yet.
Let me try that one more time.
Try that again.
Let me try that one more time.
There we go.
Okay. Okay, thank you. As Andrea's already stated, tonight we're talking about community health care and systemic racism. And I wanted to briefly describe where we are in terms of our cases of COVID and then hospitalization and death in terms of risk. The very top line there from the latest CDC data shows us that for Native Americans, about 1.7 times more likely to actually be infected with COVID. And then you can see across the board of that top line for Asian, African American, and Latinos, one would be just about an even risk. So actually being diagnosed with COVID, we find a lot of even distribution. The real change comes here when we start looking at hospitalizations. We see the dramatic effects in risk that we've seen in our communities. For Native Americans, 3.7, almost 4 times the risk of being hospitalized and 2.5 times greater risk of actually dying. When we look over at African American, same thing. So if you're diagnosed and you're African American, compared to whites, you are 3 times more likely to be hospitalized. And you are twice as likely to die if you're diagnosed with COVID. And with Latinos, you see the same thing, 3 times greater to be hospitalized and more than twice the risk of actually dying from COVID. So what does that actually look like? These are the dramatic numbers that we saw over the last year. Risk is one thing, but taking a look at what does that mean in actual numbers? Well, here are some of our early stats from early in the pandemic. You can see that in the states we were looking at, if you look at Blacks, they comprised about 18% of the population, but were being hospitalized 33%. For whites, 59%, but far less, 45% were being hospitalized. And then when we look at Hispanics, early on, we weren't really sure what direction that would go. But later on, we did find out, as we saw from the risk I just showed a minute ago. in terms of what that looks like in death, this is what the mortality looks like. If you just look, I've highlighted here whites versus blacks. So this is what it looks like if you think of double the risk. So based on race, for 100,000 people, 47 whites would die, compared to for 100,000 of African Americans, it would be 98, or actually double the number. And then we witnessed these absolutely tragic and staggering numbers early on. This is pulled from early in April last year in Washington, D.C., where we see, when we're looking at deaths during the month of April, where that line that's almost straight up is Black African Americans, versus you see the line starting to inch forward, inch a little bit higher for other racial and ethnic groups. So this is what it actually looks like, the horror that we were looking at. And I want to place that in the context of where this risk comes from.
Yeah.
We know from all of the data, not only in the US, but around the world, that most chronic diseases are preventable. In fact, 80%. And this also holds for infectious diseases like COVID as well. And in order to put that into perspective and to understand why we then have these increased hospitalizations and then these increased mortality rates among specific racial and ethnic groups, we have to understand more about what makes us and keeps us healthy. And those of us that work in epidemiology and healthcare and community medicine have known for a very long time that when you look at the factors, most people think that it's access to healthcare and genes that are the main drivers of health outcomes. But as you can see, it's really 10% genes, 10% access to healthcare. Now, of course, these are both very critical, but if you look at the social and economic factors, the physical environment in which a person lives, and then both of those condition their health behaviors, that's fully 80% of health outcomes. And this is the reason that we've come to say that zip code is a more important indicator of health outcomes than genetic code. So when we look at the social and economic factors, Sandro Galea up at Boston University has done some really fantastic work advocating for what we call change in the social determinants of health. And this is one of his studies where he shows that when you really break it down, the primary driver over the life course of poor health outcomes is education. Low education levels and challenging education circumstances really have a profound effect on the health of individuals, not only early in their life, but then it carries over into later life as well. And also other factors are low social support, what your community networks look like, individual level poverty, racial segregation, income inequality, and then area level poverty. And these collectively begin to address what we call the social factors or the social drivers of health outcomes. And what happens is, in respect to these drivers, you become predisposed to then, if you are infected with an infectious disease and you have underlying conditions or what we call inflammation that may have compromised your physical health with diabetes or heart disease or hypertension, then you become far more susceptible to the effects of an infectious agent. So let me turn for a quick look then, what we have then done to try and address these underlying conditions. I mentioned that 10% of health outcomes is related to access to healthcare. And Having been doing this work now for 30 years, the most dramatic change in the underlying conditions and all of the determinants of health actually came in healthcare with the advent of Obamacare in 2010. You can see the high levels, if you look at the left side of the graph, the high levels of uninsurance. If I just take Blacks, for example, 20% uninsured in 2010. And if we follow this through to when enrollment actually began in 2013, by the very next year, that had fallen to 14.9%, fallen to 12.1%, 10%, 11%, and you see what starts to happen. A steady fall until the election of 2016, when we began to see resistance to Obamacare. And we had seen this tremendous progress as healthcare systems now became accountable for the type of care that they were delivering. And when we also were able to give coverage to people who are sometimes called the working poor, people who are making too much money to be able to be eligible for Medicaid. And now we have to open up another pathway to getting insurance because they're not covered by employer-based care if you're in low-wage occupation. And just to give you the aggregate right here, you can see what happened in 2016. It just starts to change. After all this steady progress, it just starts to inch up again, 2016, 17, 18, and 19. And what this leads to, of course, is one, as people begin to start thinking about healthcare, as we now scale that back and reduce access to healthcare, we see staggering and troubling statistics like this. The percent of non-elderly adults who did not see a doctor due to cost in the past 12 months. And you can see among Blacks, 17%, almost 1 out of 5. And among Latinos, it is 1 out of 5. And the same thing holds for Hawaiian and also Native Americans. And then this is further complicated by the Supreme Court decision in 2012. Originally, Obamacare expanded Medicaid eligibility, and the Supreme Court ruled that unconstitutional, so it now has to be elective. So if you look down in what is sometimes called the Deep South, down here through Arkansas, Louisiana, and cutting across Tennessee and North Carolina, all of the states in red have very high proportions of African Americans, above 15%, indicated by this dark navy blue. And the red means that there has been no Medicaid expansion. So the eligibility stays very low, and as a consequence, uninsurance rates continue to stay very high. And so in closing, what this ends up meaning, our research has been looking at this for some time, not only in Dallas, but other cities around the country. And what we find is that low-income minorities with reduced access to care become less likely to receive preventive care, 3 times more likely to postpone seeking care, 4 times more likely to not get care needed, 4 times to report problems receiving care, even when they do seek care, more likely to be diagnosed not only with cancer, but with late stage cancer, and more likely to be hospitalized for preventable conditions. And so working in the area to close my comments, the implicit and explicit bias that we see in healthcare needs to be addressed. And this must also be combined with addressing the social and economic factors. And what we've discovered through our advocacy and the advocacy efforts of others is that marginal changes in the existing for-profit model of healthcare will do very little to eliminate the inherent inequities that are built into the present system. So, Andrea, I think I'll just stop there. I think that's my allotted time, and it's a natural stopping point for me, and I'll turn it over to Tony Brown now.
Professor DeHaven, that was wonderfully depressing as these types of health care and health facts always are. So now we're looking at where we are by the numbers. I want to introduce our next guest, Tony Brown. Tony hosts a radio show, and he was kind enough to invite me to be a guest on Eyes Open with Tony Brown. Tony is originally from Houston, Texas, so you and Professor DeHaven share a common birth home state, and he grew up in Lake Charles, Louisiana. He's the owner and the CEO of Eyes Open Productions, LLC, a statewide radio show and advertising agency. He's the executive director of Eyes Open Media and the executive producer and CEO of the Peabody Warhouse Radio Network. He's co-owner of 2 radio stations in Alexandria, Louisiana. He's got his BA from the University of Houston in radio and television broadcast journalism. Hence, you telling me and reminding me that you started out in TV. Tony's show, Eyes Open with Tony Brown, is the highest rated call-in talk show in Louisiana. Through that program, Tony has exposed corruption in Winfield, Bunkie, Villa Platte, and most notably in Jena, Louisiana. Tony and his program have been recognized by both the Reverends Al Sharpton, Jesse Jackson, and Martin Luther King III as the person responsible for breaking the story and coining the phrase, the Jena Six, by exposing the corrupt judicial system in Jena since the noose hanging at Jena High School in September of 2006. Tony has broadcast more than 200 hours and more than 100 radio, print, and television interviews telling the Jena Six story to the world. Tony Brown, welcome, welcome, welcome. And what I'm going to do, there we go. Thank you, Tony. The floor is yours and the mic.
First of all, I want to thank the Centers for Common Ground for having me on. I want to thank, of course, Sister Andrea Miller and, of course, Nancy Goodman for keeping in contact. And it's just a blessing to be here with you guys. I promise you, like the great man, the first Black man to walk the halls of Congress, a distinguished gentleman from Harlem, like he once said a long time ago, I should keep my remarks like that of a woman's skirt, long enough to be respectable, short enough to keep it interesting. So we're going to keep it moving here. And we're going to say here in Louisiana, we've been devastated. The headline 2 days ago in The Advocate, it's like 6 Katrina, more than 10,000 suspected of dying from COVID-19 here in the state of Louisiana. What I would say about Louisiana is we tend to have the undubious distinction of being at the top of the list when it comes to the bad stuff and at the bottom of the list when it comes to the good stuff. But I can attest to you today that Louisiana has done exceptionally well of getting the information about getting the vaccine, making sure that certainly through our governor, John Bell Edwards, who's done a remarkable job of making sure that equitability as it pertains to access to information and getting the vaccine has been his top priority. He recognized that Louisiana, we have the Blackest state in America. you know, our African American population makes up nearly a third of the population, right about 33%. And I'm here to boast about, uh, unlike the national average of the African American vaccines, which is running, I'm told, the figures I got last week, somewhere about 6 or 7%, maybe about 10% in the Latino community, and a whopping 6% in the Caucasian community. Here in Louisiana, African Americans make up about 23% of the population that have gotten the vaccine. So it's just about 10% off where we should be. But unfortunately, the overall vaccination rate here in the state of Louisiana is running probably close to the national average of about 10 to 15%. So we still have a problem. Uh, Hesitancy is a big problem. Access initially we thought would be a problem, but that turns out not to be the case. Hesitancy because of past situations and the government. You know, we can go back to Tuskegee syphilis story. We can go back to the eugenics movement. We can go back to Jim Crow and even slavery when African Americans, particularly here in the South, were used as lab rats and guinea pigs. We can go back and talk about that even to this day, as Andrea and I were saying just day before yesterday on the show, that we still have some racism in the health system. Uh, Doc has pointed that out. Dr. DeHaven, I agree with a lot of what he said, and certainly the facts and the data speak for itself. But there's a human story to this. I can share a story about a good friend of mine who I looked up to when I was coming up in the projects in Lake Charles, Louisiana. I was in middle school, and across the street was the big Lake Charles High School, and we had this stellar athlete. His name was Orlando McDaniel. He was incredible. He went on to become a football player at LSU. After that, he played a few years with the Denver Broncos and moved to Dallas, got married, and in fact started a girls track club called the Cheetahs in Dallas. Dr. DeHaven, you may be familiar with him since you're in the Dallas area, but he's actually been attributed to sending at least 14 young Black girls to the Olympics through his efforts as a track coach in his later years. Unfortunately, he was the first person that I knew that died of COVID. He had been in Washington, D.C. He flew home to see his mother, who was suffering, mind you, from Alzheimer's. And he was feeling well, but just before he made it back to Lake Charles, he flew in, visited his mom. Thank God he didn't get COVID to anybody. He wasn't even able to make it from Lake Charles to his home. He went straight to the hospital, and he never made it out, leaving two wonderful daughters and a wife. I can also tell you about my good friend, Lloyd Thompson. Lloyd Thompson has been a strong friend of mine since he and I would often run into each other at the state conference of the NAACP. I happen to be the vice president of the Central Louisiana branch here. And he's the vice president of an entire region up in Shreveport. So we would communicate, obviously get together, to talk about and do the business of the NAACP. I look forward to seeing him every year at the state conference because prior to the business being taken care of early that Saturday morning, often we had a little free time on Friday and he and I would go to dinner. It was a tradition for the last 20 years. I hate finding out maybe a month after he won an election, his first bid for election in the Caddo Parish School Board, that he died of COVID-19. So I'll never have the pleasure of sitting with my friend, having dinner on a Friday at the state conference of the NAACP. I can also tell you about a mentor of mine. When I first came to this town, there were a few men who had been around. One was an attorney, an African-American attorney, one of the first, maybe 2 or 3 African-American men be accepted to the bar here in Rapides Parish in Central Louisiana. As many of you may not know, I'm smack dab in the middle of what I call 12 years of slave country. This is the area in which, of course, we can talk about the man who was kidnapped right there down the street from the White House out of Capitol and then served 12 years as a slave, right here where I'm standing, right here in Woodward, right here in Alexandria, right here in Bunker, Louisiana. It's also the place where just up the road, we had the Colfax Massacre, where upwards of possibly 200 or more African Americans were shot indiscriminately in the street after having taken office after Reconstruction. You can look that up. Also here in Alexandria, we have something called the Lee Street Riot, where in the 40s, it is said that upwards of 200 Black soldiers, many of them from New York, who came down here, and there was an incident in downtown, and next thing you know, white folk rioted, grabbed their guns, and just started shooting black people in the street. Unbeknownst to this day, many of them, the families of those, many from Brooklyn, New York, whose loved ones were buried at black funeral homes because segregation existed back. Then their bodies were put on trains and then shipped through ports and bases throughout the South. And to this day, those family members think that their loved ones died in training accidents. So we still got a history here of racism. It's still being covered up. But I'm proud to say that we're doing a lot better. And the simple fact that I'm honored that Louisiana is #1 in the country when it comes to second vaccine. Unfortunately, we have 10,056 deaths. That's the latest number that I have here. That's an extremely devastating loss. And when I go back to talk about Mr. Ed Larverdane Jr., the attorney I was telling you about, who actually back in the 50s and the mid 50s actually entertained and hosted one of the hosts for Dr. Martin Luther King when he came and spoke here to actually start for the last 20 years, it was just an honor to go to his office. He was still practicing well into his mid to upper 80s. And when you would go to his office, both of his sons are attorneys. One of them was a state representative and one was a city councilman. So they grew up being active in the community. I'm talking about his son, Malcolm Xerxes Larverdane and State Representative Ed Larverdane. But just maybe 2 or 3 weeks ago, he died of COVID-19. What I enjoyed and loved and will miss most about him is visiting his office and always feeling like it was an honor to, when you go into his office, you know that he didn't have an office per se. His office was the break room, and there was a door to the break room. So if he heard your voice and he wanted you to come into the break room, which was an honor, I felt it to be an honor, he would creak that break room door open and then he would look. So I always got called to the break room every time for the last 20 years that I went to his office to do something, just so he could sit down and ask me what was going on in the community. I'm not going to have that opportunity again. So I've lost 3 friends to this. I'm not talking about data. I'm not talking about statistics. I'm talking about what has affected me, my life, and the people that I care about so dearly. So I'll say this about Louisiana, is that we're doing exceptionally well with the vaccine and getting it out. I just had the Secretary of the Department of Health and Hospitals, Dr. Courtney Phillips, on my show just last week. There's a new initiative that has gone out. The governor just announced just yesterday, and I happen to break that news because I love breaking news as a journalist, that the state would be open up to everyone, every adult, even children 16 and older. So Louisiana has been very progressive in making sure that that we get the vaccine out to people. Not only that, there's been partnership, collaboration between the government, the local municipalities, as well as the hospital. Right now in Central Louisiana, and I have to give credit to our medical director for the Office of Public Health for Region 6, Dr. David Coker, who's been tirelessly working on this thing. I could hear him, see him quoted in the paper just the other day, to deal with this pandemic. And then here in Central Louisiana to deal with 4 or 5 hurricanes right after the pandemic, and having to stand in shelter for nearly 100+ days and operate a shelter. So Central Louisiana has had its portion, its share, not only with the pandemic, but dealing with those hurricanes that we dealt with back to back. And then we had the big freeze here just a couple of months ago that knocked out power for most throughout the state. So I have to credit him, certainly keeping my listeners abreast. Obviously, for the last year, he's been on a minimum 3 times a week, many times at my expense. And that doesn't matter to me about the cost and expense because I really care about my community. And like any person, I want my listeners, who I consider my family, to be around. So that's why I put the show on the air more than 20 years ago. Well, almost 19 years ago. Our anniversary is next month, actually, our 19-year anniversary. We started out with 1 hour because I wanted to give particularly African Americans access to information that would help increase their quality of life. I want to talk about healthcare. I want to talk about education. I was talking about 19 years ago, unarmed Black men being killed at the hands of police here in Louisiana. Way way before Trayvon Martin and Eric Gardner and George Floyd, I recognized it was an issue, particularly here in our state. And that's why I put the show on the air to address the issue. So to God be the glory that we started out buying airtime on one station, a non-commercial station. And today I can say certainly through his grace and just the popularity of the show, having a strong listenership and just volunteering and tirelessly giving people access information to increase their quality of life, we now have expanded the show to 3 hours. And I now am on the stations that I co-own, 2 stations, FM 107.5, which we just got on the air last month, and we own the station 1110 AM KPP. So I'm proud to say our primary purpose of owning media, me and my business partner, Martin Johnson, is that we have to be allowed to tell our story. You know, there's an old African proverb many of you are familiar with, until the lion tells his story, the tale of the hunt will always glorify the hunter. You know, we are the lion, and we recognize that we have to have a good, viable product, not just song and dance, because anybody can give you song and dance, but not a whole lot of markets are giving information about health care, where to get health care, how to apply for Medicare, how to go vote. We just partnered with Black Voters Matter last week on a very crucial election in which we dropped the ball because of voter suppression, because of lack of access, and just us not going and do what we needed to do to vote. We had an opportunity to put the first Black woman in Congress. And as many of you know, and I interviewed him, Luke Letlow, how bad did the COVID-19 impact us? Well, this young man was about to take office. 5 days he was supposed to take office in the United States Congress. He died of COVID-19. And just this past weekend, Louisiana overwhelmingly elected his wife, Julia Letlow, into that position. So I can talk about how it impacted me personally. I can tell you how it's impacted our community. I can tell you how it's impacted our state. But I will say this, Louisiana has done, believe it or not, a very tremendous job in getting it out. I just heard about a possible initiative between the Southern University system, their foundation, and getting together with other partners to make sure that African Americans who are being left out and who are being hesitant for a plethora of reasons, we could talk about that, that's a whole nother show, that the schools and the HBCUs start getting involved. And as you know, here in Louisiana, we have 2 of the most powerful HBCUs in the country, the most traditionally with the historic past of getting started right during Reconstruction, many of them over 100 years old. We're talking about the great world famous Grambling State University up in Grambling, Louisiana, of course, down in Baton Rouge, the only Black university system in the country with 5 universities, Southern University as well. So I'm a product of the public health system in Louisiana. I grew up, I was born, believe it or not, in Houston at a charity hospital when we moved here. I'm a product of the public housing system, having grown up in the projects, public school system, having graduated from Lake Charles High, and the university system, having graduated from the University of Houston. So I love my state. I know many of you guys love it because every chance y'all get, y'all trying to come down to New Orleans and pass a good time. But that's okay. We love y'all. We want y'all to come back. And let me tell you, we are doing a marvelous job of much better than most of our counterparts in the South are doing, and make sure that vaccine is getting out to the arms. And like I said, the initiatives between the cities, we have a clinic. We had a clinic. I don't know if it's still up, but we had one in Main Street in Pineville, Louisiana. That was a collaboration between both hospitals and the city of Pineville. We had one in the Bolton Avenue Community Center in Alexandria across the river. We had another collaboration between both hospitals who would normally be competitive for the past 80 years. So everyone has come together. We have a federally qualified healthcare system, and Mackey's Primary, they've been doing it in the south portion of town and making sure that the vaccines are getting to those folks. Of course, Dr. David Holcomb, our medical director, has a big, huge operation at the Baton Rouge Coliseum, and that's been doing extremely well. So we're now to the point where we're having more doses of vaccine than people who are actually coming up to get the shot. And I think many of the states are suffering from the same thing. So again,
Tony, I'm going to say thank you. Stop you right there so that we can bring Professor DeHaven back on, and we can do some Q&A.
Thank you for having me.
We love questions and answers. We do, we do, we do. All right, Professor DeHaven, I'm going to give you this question first. The government's response has been basically, we're going to focus on the disease, how is it being transmitted, and now we're doing the vaccination. But there haven't really been any long-term, long-lasting interventions. So a lot of what you showed in your charts said, yes, we've got the basics down, but we've got some systemic issues that are not going to be addressed by a simple vaccine. What concrete actions can be taken to make lasting change and begin to correct the structural problems that put communities of color at higher risk?
Well, thanks, Andrea. The most frustrating part, I think that I really appreciate Tony Brown's comments by the way that personal lives of people have been touched. And when you're talking about these systemic changes, we saw a more dramatic escalation of personal loss during this last year of COVID. But for many people, that personal loss is there always because of the high incidence of chronic illness that is related to the social and economic circumstances in which people are living and the lack of access to care. So one thing that's going on that's been a very positive change, the most of my NIH funding, for example, comes through the National Institute of Minority Health and Health Disparities. And that institute, for example, Dr. Fauci's institute is allergy and infectious diseases. And the NIH is comprised of about 27 different institutes. Well, NIMHD has been notoriously underfunded for years. As a consequence, we really don't know. My team in Dallas and the work that we've been doing for 20 years and scattered groups throughout the country have been working to try and develop the more progressive approaches and more progressive models. I see my friend Sue Pickens Owens on the call tonight, who is a member of our team in Dallas from the great Parkland Health and Hospital system with their extensive COPC system. So one of the things that's going on, the NIH is now going to be expanding the National Institute of Minority Health and Health Disparities and now increase its funding. It has been so underfunded that we've not been able to look at the kinds of models we need to. The second thing I'll just mention briefly, national foundations are starting to find out that it's very important that community-based organizations run by people of color that are serving people of color do not necessarily conform to traditional ways of meeting the needs of people in communities. And for the longest time, foundations have thought that there's something wrong with that. They're finally understanding there's not something wrong with that. Those organizations are extremely effective. They just don't conform to this traditional way of doing business. So now we're seeing progressive funding models developing just during this past year. And we've been advocating for it among the donor community here in Dallas. We know many African-American leaders in communities that are doing fantastic work and cannot get funding because of the way that the funders do it. Well, now we are saying, and we're finding the responses locally and nationally, fund the individuals, fund the people who are doing the work. These people are going to be successful. They've been doing this work for decades. They know how to do it. And if we can support them, empower them to do the work that needs to be done, rather than the healthcare system trying to now medicalize the community. So those are two very positive things, Andrea.
And thank you very much for that. That sort of leads me into, you actually answered all three of the questions that I had. At the end, you gave us and this is what's giving me hope. So I'm going to go to you, Tony. Tony, what do you think needs to happen to achieve that lasting change? And you talked about some really great things happening in Louisiana. That's very, very exciting. And then also, is there anything else that is giving you hope that once we get beyond this situation we're in, we're going to be able to make the real structural changes that we need?
I think everything that you just asked me and what the doctor's talking about is a residue of poverty. Poverty is our biggest issue. Where you live, access to healthcare. We fortunately have federally qualified healthcare centers, and we have I call her a beast, Patricia Lewis, over ours, who frequents Washington D.C., knows how to get the access to the funds that she needs to run an effective program. In fact, they've built two additional sensors, a substation, a sub-medical centers, one in Bunkie, Louisiana, and then another one in another portion of Alexandria, right across the street from big housing, public housing facilities. So, fortunately, they've also been very instrumental in getting the information out back about COVID-19 and actually been engaged from almost day one that the vaccination was made available. Also bringing the vaccine to the parks way before many other people were doing it. We now have churches that are opening up as well and taking the lead, particularly, here in the South, in most portions of the South, the African American church, cornerstone of the community. So they're now opening up, finding out what they need to do. One thing that I'm not hopeful about, particularly in our city, is as a result of people being sheltered in place, as a result of mass loss of jobs, businesses closing up, and just the depressing state of affairs, economically speaking, for people who already had a high rate of unemployment. Mass incarceration seems to be a huge problem. And this addiction to heroin and fentanyl that is running rampant through our communities has led to Alexandria now, as I talk to you today, for a city roughly of about 45,000, we have had 16 murders so far this year. And running at this rate, we're going to top 60 murders. So we have the highest murder rate per capita than any city in the state. It's tied to the pandemic. We haven't seen this since the early 90s of the crack epidemic. Methamphetamine wasn't this bad. So now we're having not only that, an alarming amount of not only murders, but drug overdose that many people are not talking about. So the pandemic has stretched to where the jails are at capacity. Unemployment is at a high rate, but we've always had to deal with these societal disparities that lead to health disparities as well. Again, because I think our area and our doctor in our region is way ahead of the curve for the last almost 10 years. He came on my show and we talked about, the disparities when it comes to STDs and many other health chronic situations in the African American community. And he's been doing a forum, a health and societal disparity forum during Black History Month, almost the last 10 years. So unlike most places in the South, I said we're faring better because we have progressive people in positions here, not only with a progressive governor who is the only probably Democratic governor in the South. So I'm hopeful that we will continue to make progress and make sure that we get the shot in every arm. And right now, DHS is spending a lot of money in marketing and getting the word out. It's a campaign called Sleeves Up. And I think that's going to be a bright shining star to make sure that people get shot in the arm. Certainly need.
Thank you very much, Tony. Professor DeHaven first. My question is, and again, I'm going by the last slide, your last reference was the fact that the for-profit healthcare system is in and of itself just carries built-in systemic problems. So do you see a solution, say, if we were to move to Medicare for all?
Yeah, these are the solutions, Andrea, that begin to eliminate the profit motive in favor of equity. Right now, healthcare is either the fourth or third largest industry in America. That's healthcare, and I'll repeat that, it's an industry. It accounts for 17.8% of our gross domestic product, GDP. And the reason why it's hard for me to endorse any kind of marginal changes to that system is because it's designed to make a profit at the expense of people who are suffering especially the consequences of the systemic components we're talking about. So when we look at, finance and real estate are the two biggest, and we already know the discriminatory practices in finance and real estate. We've been following them for the last 50 years. And, without being too critical of healthcare, all industries have a built-in bias. And in healthcare, that built-in bias is an implicit bias. It's the one that is not spoken, and it's based on the ability to pay. And if you don't have the resources to pay, the bias is that you're left out. And in an equal world where we all had equal opportunity, well, then there may be something to that. Maybe that works. But we all know that we don't have equal opportunities. So until we have equal opportunities, the reform is really, I think, the only reasonable approach, and it has to do with a single payer system. It's Medicare for all, the M4A. It is expanded Medicaid. All the Organization for Economic Cooperation and Development, all the European countries, we're the only ones. We spend per capita about $12,000 per person on healthcare in the US. The next closest, I think, is half of that.
Yes.
And it's not a sustainable model. It just, the ultimate goal is to, like any industry, is to sustain the profitability of the industry. So that's the long answer to a short yes, Medicare for all.
Thank you very much. One of the things that we started saying, and this is going all the way back to probably 2008, and unfortunately, it's still true, that the United States, we are number one in healthcare costs. However, we are, I believe it was number 37 in terms of healthcare outcomes. So for all the money we spend, we aren't really producing healthy people. So I'm going to thank you both So Professor DeHaven, this was really great. I think we are going to work some more on Medicare for all. I saw you quietly going over there, and I am delighted that's really where you were going. Um, Tony, Tony Brown, you and I, we are going to need to be causing some good trouble down there in Louisiana. And one of the things that I am delighted about is that folks in Louisiana, through you, you're giving them a voice, you're being able to feed them the information that they need. So good on you, Tony Brown. Thank you very, very much now for all of our Center for Common Ground folks. Thank you for joining us tonight. You should know we've got phone banks that are running. We are still calling Georgia. We are now going to be pummeling Governor Kemp because SB 202, the really horrible bill in Georgia, it did pass. And remember, this is the bill that criminalizes giving people standing in line food and water, among all the other things, um, lowering the number of days for early voting and all those different things. So Gabe is with us tonight, or any other members of the team. The chat is running. We can drop in where you can go and get phone banking information. I will see most of you, some of you next week. Next week, I think it will be right. It's the 5th week. So I'll be doing another road to the midterms. We're going to be looking at where we are. We hope we are going to have the data for Virginia. So we will be ready to start building Virginia phone banks, because Virginia has an election that is coming up this year. The entire statewide ticket, all 100 of our House of Delegate folks are up for election slash re-election. So we've got an election year. Our rural electric cooperative initiative has started. I am meeting with the Southern partners on that on an ongoing basis now. I saw people are going, yes, Virginia's back in the game. Yes, we're back. Reverend Leo, Reverend Woodbury, I saw you here. Let me see if I still have the link. I just dropped the link in where you can read about Reverend Woodbury and his Clean Water Initiative in South Carolina. So not only are we concerned about the impacts of COVID, we are still concerned about the fact that so many people in the South and Flint and various other parts of the country do not have clean, safe drinking water. We still are fighting pipelines. In short, all the old fights that we were in, we are still in those fights. The one thing that we can definitely say is we can actually see that there is a light at the end of the tunnel on COVID, but we are really going to have to work to make certain that we get there as quickly as possible, and that we do not continue the Hunger Games style of who is going to get the vaccine and who isn't. So I learned a lot tonight. I saw a number of people saying, are we going to be able to get the slides tomorrow or the next day? Everybody that was signed up, and we had more than 300 people signed up, you will get an email, and in that email, there will be the link to the recording of this video, and there will be the slides will be available as well. So yes, we're I see a lot of stuff going on Medicare for all. So again, it is wonderful. I love spending my Thursday evenings with all of you. Take care.